Hi, this is Jennifer Kaur. I'm a breast imager at Virginia Mason Medical Center in Seattle. I'm going to be reviewing diagnostic or problem-solving mammography. I will cover standard and additional or supplementary mammographic views for lesion localization and characterization, including one view findings. I will also cover mammographic and ultrasound evaluation for breast symptoms, including palpable lump or focal thickening, nipple discharge, and pain. I will also briefly cover some tomosynthesis during this talk. Please note that there are separate lectures covering mammographic image interpretation, Bio-Rad's lexicon, and symptoms in men and pregnant or lactating women. Beginning with the standard mammographic views. This is an MLO or medial lateral oblique view, which refers to the fact that the X-ray beam travels from medial to lateral aspect of the breast with the detector along the lateral aspect of the breast. The oblique title refers to the fact that the image is obtained along the parallel axis of the pectoralis, which is oblique to the sagittal and axial planes. The benefits of this view is that it provides the greatest coverage of breast tissue, extending from the axillary tissue to the inframammary fold. However, it risks excluding the far upper inner portion of the breast tissue. Additionally, there is generally less uniform compression of the breast tissue, largely due to the inclusion of the pectoralis muscle, which is denser than breast tissue. Moving on to the CC or craniocaudal view, there's an image of a patient getting this view, and the name refers to the fact that the X-ray beam goes from the cranial to caudad surface of the breast with the detector along the inferior aspect of the breast. On the right side of the screen is a standard CC mammographic image. By convention, the lateral aspect of the breast is at the top of the image and the medial aspect of the breast is at the lower portion of the image. The CC view provides better visualization of medial tissue, more uniform compression, largely because of the exclusion of the pectoralis muscle, but it does tend to exclude some posterior and superior tissue as well as axillary tissue. Moving on to supplementary or additional views, we'll start with the spot compression view. For comparison, the diagram shows the standard CC view with a standard or full paddle, providing full compression of the entire breast. In comparison, a spot compression view is obtained with a spot paddle or a much smaller paddle. This provides focal compression over the area of interest. It effectively brings the area of interest, as depicted by a gray circle here, closer to the detector. This results in reducing geometric unsharpness and will reduce blurring of the image. Spot compression can also be used to separate overlapping structures. As seen at the top of the diagram, the structures are actually separate in the breast, but in the image appear to be overlapping and can mimic a true lesion. Spot compression, as seen on the lower portion of the diagram, will spread apart the different structures and show that there is no true lesion. This is called superimposition and refers to the fact that different areas of the breast are superimposed, creating a pseudolesion. And here's an example. This is a right CC view obtained at the time of screening with a possible lesion shown here in the posterior central aspect of the breast. The patient was recalled from screening, given a Bio-Rad 0, and additional views were obtained. This is a spot compression view obtained in the CC projection of the area of concern. And you can see that there is no persistent denser area, consistent with superimposition. Moving on to another example, you can see in the CC view, there is a denser area in the posterior lateral aspect of the breast, but there is no similar area of density in the posterior aspect on the MLO view. The patient was brought back for additional views and started with a spot magnification, which I'll talk about in a moment, view of the area of concern. And you can see that the breast density appears more uniform on this view without any focal area of increased density. In this case, just to be sure, a full CC was repeated, and you can see that there is no persistent dense lesion. And this was consistent with superimposition. Moving on to another example. This is a right MLO view obtained at the time of screening, and there is an area of increased density in the superior breast as indicated by the blue circle. And here's the same image just blown up so you can see the detail a little better. There was no correlate seen on the CC in this patient, and she was brought back for additional views. And this is a spot compression view of the superior breast, and you can see that the area of question actually became denser, and there even appears to be some architectural distortion associated. And this turned out to be a solid mass on ultrasound, was biopsied, and proven to be an invasive breast cancer. Here's another example of a screening finding. There's a subtle area of slightly increased density in the upper outer portion of the left breast, as indicated by the blue circle. The patient was brought back for spot compression views of this area, and you can see on these additional views, the area became denser and demonstrates that there is an irregular mass corresponding to the finding seen at screening mammogram, and indeed, this turned out to be an invasive breast cancer as well. And here's an image from a palpable workup. You can see on the left side of the screen, this is a blown up view from the full CC view. The round bright area to the left is the BB marker indicating the area of palpable concern. And on the right side of the screen is a spot compression CC view. So recall, this would bring the lesion closer to the detector and decrease the geometric unsharpness. And as a result, you can see that the margins are microlobulated and indistinct. You can also see just below the mass are some calcifications that are better depicted on the spot compression view. Generally, calcifications are better seen with magnification, but spot compression can also bring them out as well. So, in summary, spot compression views, when to use these. We've talked already about the workup of screening findings, and we're talking specifically about soft tissue or non-calcified findings. Spot compression views can help differentiate a true lesion, which generally will become more apparent and denser with spot compression, versus superimposition, where overlapping breast tissue is separated and shown to be a pseudolesion and will blend into the background tissue, so it will not become denser as a true lesion will. Spot compression views are also useful for focal breast symptoms. You can take a closer look at the symptomatic area. You can also include difficult to image locations such as the far upper inner quadrant, the far lateral quadrant, and the axillary portion of the breast. Moving on to magnification views. These can be used alone or with spot compression views, which are called spot magnification views. The image on the right side of the screen demonstrates the setup for actually a spot compression magnification view. You can see there's a spot compression paddle, which is the small focal paddle, as well as the plastic mag stand, which creates an air gap. What this does is effectively brings the lesion further away from the detector, as demonstrated by the diagrams on the left side of the screen. Bringing the lesion further away from the detector results in it falling on a larger number of pixels so that spatial resolution is increased. So here's an example of another screening mammogram finding. You can see on the left CC view is an area of increased asymmetry or density, as well as some possible architectural distortion, and this is just medial to the level of the nipple. There's a possible correlate in the inferior portion of the breast on the left MLO view, so lower inner quadrant. The patient was brought back, and magnification views were obtained over the area. And you can see on the magnification views, we are now able to much better appreciate the architectural distortion, which is the alternating white and black lines radiating to a central point, best seen on the CC magnification view. And on the magnification view in the MLO projection, you can see there's a denser area at the center of the architectural distortion consistent with a mass. And this turned out to be a solid mass at ultrasound, biopsied, and was invasive ductal carcinoma. So here's a summary between spot compression and magnification supplementary views. Spot compression in review will separate overlapping structures, and this can help determine a true lesion versus a superimposition of breast tissue. A true lesion will get denser with spot compression, whereas superimposition will blend into the background breast tissue. It's also good for difficult to reach areas of the breast and can be used with magnification or a spot magnification view. Magnification predominantly works by increasing spatial resolution of the finding, and this is best for calcifications, architectural distortion, and mass margins. Moving on to localization. Accurate localization of lesions is a must in order to direct the next steps of workup and to be sure that you're appropriately evaluating the area of concern with ultrasound. This is also important to correlate with any focal symptoms and biopsy planning. Predominantly, a clock-faced position is used to describe findings and location in the breast. Note that these are different for each side of the breast. For example, a finding in the upper outer quadrant of the right breast will be between 9 and 12 o'clock, whereas a finding in the upper outer quadrant of the left breast will be between 3 and 12 o'clock. So we're going to be talking about some mammographic localization tools to help localize findings. Ideally, we want to localize a lesion to at least a quadrant and ideally a clock face position. We have views listed here: true lateral, rolled CC, exaggerated CC views, and tomosynthesis, which we'll talk about in that order. Starting with the true lateral, sometimes called straight lateral or 90-degree view. This is a multi-purpose view and can be done in the medial lateral or lateral medial projection. And again, just like on the other views, this describes the direction of the X-ray beam. A medial lateral view is depicted here, with the X-ray beam going from the medial to lateral portion of the breast and the detector along the lateral aspect of the breast. And here's an example of an actual mammographic view of an ML image, mammographic image. These are useful for lesions seen only in the MLO view and not visible on CC. They can also help determine if the lesion is real. For example, if it's seen only on the MLO view and not on the lateral view or spot magnification, it most likely represents superimposition. It can also help determine where the lesion is in the breast, as we'll talk about in a moment with triangulation. Additionally, often stereotactic biopsies, as well as mammographic wire localization, is performed either from a 90-degree projection or CC, so it also helps with procedural planning. Additionally, when true laterals are used magnification with calcifications, it will show classic teacup finding of benign calcifications, which I will demonstrate in a moment. One thing to note here is on this MLO view, for example, is you don't see any pectoralis. In comparison, here is an MLO view on the same patient showing much more pectoralis. So the risk of the true or straight lateral view is the exclusion of posterior tissue, particularly axillary tail and axillary tissue. So here's an example, as I mentioned, of benign milk of calcium. It's important to do a true lateral magnification views to best depict the teacup or semilunar crescent-shaped calcifications on the lateral view, in contrast to the en face appearance on the CC view of the smudgy amorphous calcifications. So moving on to triangulation and the use of full laterals in triangulation. This is a schematic to demonstrate how that works. Starting with the MLO view here, you can see that there is a lesion centered right behind the nipple. And we don't know whether that lesion is in the medial or lateral breast by looking at this view, as there was no correlate on the CC view. So the next step would be to get a true lateral view. And this shows that this particular lesion rose or went to the superior aspect of the breast on the lateral view, indicating that the lesion is in the upper portion of the breast. What this means, if you follow it through, is that since the lesion rose on the lateral, it's actually in the medial portion of the breast. So since this is the left breast in this example, that would be in the 10 o'clock region or upper inner quadrant of the breast. In contrast, if you saw a lesion only on the MLO view that actually appears slightly above the nipple, and you get a lateral view, and the lesion falls or drops down inferiorly relative to the MLO view. This particular lesion is now in the inferior aspect of the breast, and because it fell on the lateral view relative to the MLO view, that indicates that it's in the lateral breast. And since this is the left breast, that would be around 4 o'clock in the lower outer quadrant. The mnemonic here is lead falls, muffins rise. So if a lesion falls on the true lateral, it's in the lateral breast. Lead falls. If the lesion rises on the true lateral, it's in the medial breast. Muffins rise. So the lead is the L, meaning it's in the lateral breast, and the muffin is the M, meaning it rose and it's in the medial breast. Here's an example of a one-view finding and how we localized it. You can see here in the superior breast on the MLO is a focal lesion, and there's no correlate on the CC view. In this case, a full lateral was obtained, and you can see there is a persistent lesion there, suggesting this is a true lesion. And you can see if you line up the nipples that this lesion fell from MLO to the lateral view. So lead falls. So this was in the lateral breast. And we performed an XCCL in this patient and showed indeed the lesion had a correlate in the lateral aspect of the breast. An ultrasound was performed and we found the mass, and this turned out to be a high-grade invasive ductal carcinoma. Moving on to rolled CC views. These can help localize CC-only findings. By convention, the superior portion of the breast, the way the superior portion of the breast moves is how the image is named. For example, if the superior breast is rolled lateral, it is a rolled lateral view. If the superior breast is rolled medial, it is a rolled medial view. And I'll show an example of this. Not only can the rolled CC views help confirm that a lesion, not only can the rolled CC views help localize a lesion as into the superior or inferior quadrant of the breast, it can also help determine if a lesion is in fact real. For example, if a lesion does not persist on the rolled CC views, it was likely superimposition. Moving on to an example, this is an asymmetry seen on a screening mammogram only in the CC view, just medial to the nipple on the left breast. So the patient was brought back. In addition to a spot compression view, we also did rolled CC views. So here's the full CC view obtained at the time of screening with a lesion indicated by the blue circle. A rolled medial view was obtained, so this means the superior breast tissue was rolled medial. And a rolled lateral CC view was obtained, meaning the superior breast tissue was rolled laterally. And you can see here we've lined up the nipples and the lesion rolled with the superior breast. So on the medial CC rolled view, the lesion went medial, and on the rolled lateral CC view, the lesion went lateral. This means that the lesion was in the superior aspect of the breast, and we already knew it was medial given the full CC finding just medial to the nipple. So this means it's in the upper inner quadrant, and in the left breast, that was around 11 o'clock. And this turned out to be a mass at ultrasound and was a fibroadenoma. Moving on to exaggerated CC views. So at the top of the image is a standard full CC view. And then at the bottom is the exaggerated lateral or XCCL and exaggerated medial or cleavage views. And you can see the exaggerated lateral obtains more lateral tissue and the exaggerated medial obtains more posterior and medial tissue. And here's an example of how these types of tools can help localize a finding seen on a CT or other imaging findings. So this was a follow-up CT chest, abdomen, pelvis for metastatic pancreas carcinoma, and a new mass was seen superior and medial to the nipple in the left breast on CT, or in the upper inner quadrant. And there it is, photographically enlarged. So the patient was sent for a diagnostic mammogram, and we did the routine views, the CC views, and the MLO views. The bright object in the axilla on the right is the patient's port as she was receiving chemotherapy for the metastatic pancreatic cancer. And you can see here, we don't see any correlate to that finding seen on CT. So what we did in this patient is we actually went and examined her and we were able to feel it. And we put that bright BB marker there and we did an XCCM spot compression view. So an exaggerated CC medial and a spot compression view combination, as they can be done with the full paddle or the spot compression paddles. And you can see here, just on the edge of the image is an irregular mass. We did an ultrasound, found the solid mass, biopsied with ultrasound, and it did turn out to be metastatic pancreatic adenocarcinoma to the breast. So this is just a good example of how we can use these tools to help find things and confirm that what we see on ultrasound is indeed what we saw in the mammogram, which is indeed what we saw in the CT. So in summary, mammographic localization tools are shown here. So true lateral. This will help localize one-view findings. Remember, if you have a one-view finding on an MLO and it falls on the lateral, it's in the lateral aspect of the breast, or lead falls. If you have a one-view finding on the MLO and it rises on the true lateral, it's in the medial part of the breast, or muffins rise. True laterals are also used for pre-procedural prep and can help determine if a lesion is a true lesion or superimposition. Rolled CC views will help localize CC-only findings and also help determine if a lesion is a true lesion or superimposition. Exaggerated CCs are mainly to help get more lateral and medial tissue posteriorly and may in fact be the only way to see far lateral or medial breast tissue. And note that all of these, the true lateral, rolled CC views, and exaggerated CC views, can be done as full views with a full standard paddle, spot compression, magnification views, and of course, spot magnification views. So I'll briefly talk about tomosynthesis here. Tomosynthesis is performed very similar to a mammogram in terms of positioning and compression of the breast. The difference is that multiple images are taken along an arc over the breast, similar to a CT. This allows a virtual stack of slices to be created through the breast and allows us to help differentiate superimposition of breast tissue from true lesions, also called unmasking. And I'll play a video here of us slicing through this CC view on the left. And this was a negative CC view. Moving on to a case example, these are the standard 2D views of the left breast in MLO and CC projection. This patient has scattered fibroglandular breast tissue and no lesion really stands out. None is denser than the background tissue. And these are selected slices from the tomosynthesis stacks. And you can see on the left side of the screen, this is a slice from the MLO view. And there's a bar on the right side of the image with a L on top and a M at the bottom. And this refers to lateral and medial aspect of the breast. The horizontal bar that's closer to the L indicates that this slice is much closer to the lateral aspect of the breast. And this is how tomosynthesis can help localize one-view findings, is we know this finding is in the superior aspect of the breast based on the MLO view, and then we know that it's in the lateral, so upper outer quadrant, based on the sliding bar. This finding was a two-view finding, so we already knew that was in the upper outer quadrant, but this is, again, very helpful for one-view findings. Similarly, on the CC tomosynthesis slice, there is a bar to the right that has an H at the top and an F at the bottom, referring to head and feet. And the horizontal bar indicates that this finding is much closer to the head, or in the upper portion of the breast, and again would allow us to localize a one-view CC finding into a quadrant. So moving on to mammographic and ultrasound evaluation of breast symptoms. So we'll start with the workup of palpable abnormalities. Typically, we get standard views, the MLO and CC, of both breasts, plus spot compression views of the area of concern, or tomosynthesis of both breasts. The exception is if a patient has had a recent mammogram. Our protocol is within 6 months, then we just do spot compression, CC, and MLO views of the area of concern. Tangential spot compression views can also be obtained. And this is where the BB marker is placed at the area of concern, and the direction of the spot compression view is obtained perpendicular to the BB marker so that the BB marker appears on the skin and you look directly below the area of palpable concern in the breast. If the patient has had a mammogram within 6 months to a year, then we do a full CC and MLO view of only the symptomatic breast. Another exception is age. If the patient is less than 30, we start with ultrasound. The rationale for this is most likely, if anything is found, it's going to be benign simple cyst or maybe a probable fibroadenoma. Only 1% of all breast cancers are diagnosed in women under 30. And this is similar in frequency to male breast cancers and inflammatory breast cancer. Additionally, the patients under 30 tend to have very dense breast tissue, limiting the utility of mammography. Additionally, their breast tissue is somewhat more sensitive to even the very low dose of radiation involved in mammography. So a few cases now. 29-year-old woman with a palpable right breast mass at 9 o'clock, 11 centimeters from the nipple, and the mass measures approximately 3 centimeters in size. The sonographer starts with ultrasound because the patient is under the age of 30 and shows you this image. So we can see that we're in the right place, the right breast, 9 o'clock, 11 centimeters from the nipple. But what we have here is a mass that's just over about a centimeter. And we know that the mass was supposed to be about 3 centimeters. So this doesn't fit. So we go back in and take another look. And deeper in the breast, in the same area, we find this large, shadowing, hypoechoic, suspicious-looking mass. We adjust our settings a little bit and get a better look, and we can see that this measures just over 3 centimeters. So this is much more concordant with the palpable finding. And this is also very suspicious based on the fact that it's hypoechoic and there is posterior acoustic shadowing. So given the suspicious findings, we took a look at the patient's axilla to make sure there were no abnormal lymph nodes in addition to this finding. And we see here one of several normal lymph nodes with thin, uniform, hypoechoic cortex and an intact fatty hilum. The cortex here you can see measures less than 3 millimeters in maximum thickness. Next, we move on to mammogram. Even though the patient is under 30, we will move on to a mammogram in the case of a very suspicious finding. And we do a bilateral mammogram. This is in part due to begin the extent of disease workup and make sure there is nothing in the other breast, and also to determine if there are other lesions in the breast with the focal symptom. We put a BB marker in the area of concern as indicated by the metallic BB and the blue arrow. And you can see there is an area of increased density just behind or posterior to the area of concern. Same thing on the MLO views. We also got magnification views because we could see calcifications in this area. And you can see we got a 90-degree magnification view and a CC magnification view. We also noticed that the calcifications extended beyond the magnification views, so we sent the patient back for more images to fully characterize the extent of calcifications. So because of the suspicious findings, we move on to an extent of disease workup. And this is done at the time of the initial mammographic workup for focal palpable concern if there are suspicious findings. We want to make sure that we fully evaluate the mammographic findings and look for others to look for multifocal and multicentric disease. And as in this case, we may need to send the patient back for more mammographic views to be able to do this. It's also important to look at the axillary lymph nodes with ultrasound to make sure there are no findings to suggest lymph node metastases. And if there are, to go ahead and biopsy those at the same time as biopsying the other findings in the breast. Another case here, a 65-year-old woman with palpable left breast mass at 7 o'clock, 8 centimeters from the nipple. The mass measures approximately 2 centimeters in size, and the patient had a negative screening mammogram 8 months ago. So because of the recent negative screening mammogram, we just do the symptomatic side. And because for us, it's been more than 6 months, we do the full standard views in CC and MLO. You can see here a BB marker was placed, indicated by the blue arrow in the area of clinical concern. For this patient, we did CC views, so we did not do any spot compression views over the area of concern. We did tomosynthesis, and here's the selected tomosynthesis slice in the CC view. And you can see here by the indicator that this is in the inferior medial quadrant of the breast, or lower inner quadrant, corresponding to the area of palpable concern. And all you can really see here is some wispy tissue that looks kind of like breast tissue at the area of concern. Despite any of this, we would go on to do ultrasound. And here's what we found. A 2-centimeter, very suspicious looking mass that turned out to be a high-grade invasive ductal carcinoma. The reason we couldn't see this on the mammogram is due to its far medial and posterior tissue. If we had done an XCCM, we may have been able to see more of it. This is a good example of why we move on to ultrasound regardless of the mammographic findings. In fact, this patient wasn't terribly dense in the area of concern. It was just the far posterior location of the mass. And at least 5% of clinically palpable breast cancers will not be visible mammographically. Another reason to always move on to ultrasound. Here's another case, a 57-year-old woman with an area of thickening in the left breast centered at 4 o'clock, 1 to 3 centimeters from the nipple. She had a negative diagnostic mammogram 6 months ago for the same area and reports, along with her clinician, that it has now become larger in size. So this is a very suspicious clinical scenario. And here are the left standard views. And this was the area of concern, and you can see the breast tissue is just somewhat denser in this area, but there is no focal mass or lesion visible. Unfortunately, you can also see that there is a single dominant, abnormally enlarged axillary lymph node. So we're already very suspicious that this is a malignant breast lesion with nodal metastases. So we go to ultrasound, and there is a subtle hyperechoic irregular area that blends into the surrounding breast tissue, shown here. This was actually initially called negative. And usually the negative predictive value of mammography and ultrasound is nearly 100%, but not quite 100%. For this reason, a negative mammogram and ultrasound, as in this case, should never overrule a strongly suspicious finding on physical exam. And this patient went on to get an MRI showing this large area of non-mass enhancement, and this was biopsy-proven invasive lobular carcinoma with lymph node metastases. So moving on to nipple discharge as the workup for another breast symptom. So there's pathologic nipple discharge and physiologic nipple discharge. Pathologic nipple discharge is any one of these symptoms. So bloody or clear, unilateral, single duct, and spontaneous. Again, any of these single features will make the nipple discharge pathologic or suspicious. White, yellow-green, bilateral, multiple ducts, and non-spontaneous, on the other hand, is physiologic nipple discharge and not suspicious. So the ACR appropriateness criteria recommends essentially no imaging workup for physiologic nipple discharge. This is, you can see, a woman of any age, physiologic nipple discharge, and every imaging test is given a 1, which is the lowest and usually not appropriate. So moving on to an example of suspicious nipple discharge, this is a 32-year-old woman, left breast, single duct, spontaneous, clear nipple discharge. So she has multiple pathologic symptoms. And we'll start with the review of the workup of pathologic nipple discharge. So, of course, the patient should have a clinical breast exam first to also evaluate for other findings such as a palpable lump, area of thickening, nipple retraction, or axillary adenopathy. If the patient has not had a recent mammogram within 6 months, we do a full CC or MLO view with CC and lateral magnification of the subareolar breast. So note that this is quite similar to a palpable area of concern, with the only difference being that we focus on the subareolar breast on the additional views, and the views are done with magnification as we are looking for calcifications. If this workup is negative, regardless, we proceed to targeted ultrasound of the retroareolar breast, and we are primarily looking for an intraductal mass or other mass that could be explaining the nipple discharge. If all of the above are negative and the nipple discharge has suspicious clinical features, we recommend surgical consultation, and our breast surgeons typically order a breast MRI. Other institutions will do ductography. And note that this workup and this path is the same for any nipple symptom, for example, nipple retraction, etc. And here's back to our case example, our 32-year-old with suspicious left nipple discharge. This was the magnification view obtained in the ML projection, and I've indicated where the nipple is because it's a little bit hard to see. And you can see that there are no microcalcifications, but there is a single dilated ductal structure. Same thing is seen on the CC view. The ductal structure is right below the nipple, slightly in the upper outer quadrant of the left breast. So we move on to ultrasound, and we find a small intraductal mass shown here at 1 o'clock, about 2 centimeters away from the nipple. And this does have internal vascularity and was biopsied and shown to be a papilloma, which is the most common cause of suspicious or pathologic nipple discharge. So moving on to breast pain as the last focal breast symptom that we will talk about. The workup is the same as for a palpable concern. We do a workup for focal breast pain when it's less than a quadrant of the breast, non-cyclical breast pain. Those are considered indications for workup. It is quite unlikely that breast cancer causes pain, but there have been a handful of cases that I've seen, and these are maybe incidental, as both breast pain and cancer are common, but the standard is to do the workup for focal breast pain in the small chance that it could be a breast cancer. Here is the ACR appropriateness criteria for what's considered insignificant breast pain, and this is the opposite of focal breast pain. So non-focal, defined as greater than a quadrant, diffuse or cyclical. And basically, in any patient of any age, no further workup is needed. So here's a summary of focal breast symptom evaluation. First, it starts with the patient's age. We're going to start with patients that are 30 and older. The first step is to determine if they've had a recent mammogram or not. If they've not had a recent mammogram, and we define that as greater than 1 year, we start with a bilateral standard views with either tomo or spot compression over the area of focal concern. If the patient's had a recent mammogram, we either do a limited mammogram if it's been within 6 months, or we do the full standard views with spot compression views if it's been more than 6 months but less than a year. Pretty much regardless of what the mammogram shows, we move on to ultrasound. If ultrasound is suspicious, we do an ultrasound-guided biopsy. If the ultrasound is negative, it depends on the clinical scenario. If this suspicion is low for any significant pathology, follow-up with serial clinical breast exams is recommended. However, in the setting of a high clinical suspicion, in the patient who's already had a negative mammogram and ultrasound workup, the patient may be sent for a breast MRI and or biopsy by palpation. For women under 30, the workup's pretty similar, but we start with ultrasound. And I've given 3 possible outcomes. So we may have a probable fibroadenoma, which looks pretty much like a fibroadenoma, and chances are very good it's a fibroadenoma. In that case, the patient may undergo follow-up with ultrasound, or if she prefers, an ultrasound-guided biopsy. If we have suspicious findings on ultrasound in women under 30, just as in the case example I showed, we actually move on to a bilateral standard views and with either tomosynthesis of spot compression to look for additional disease and start to do an extent of disease workup. If the ultrasound is negative, it's the same for a patient 30 and older. If it's low suspicion clinically, then follow-up with serial clinical breast exam is recommended. If it's a high clinical suspicion scenario, then the patient should be sent for a mammogram, as this hasn't been done in women under 30, and then subsequently get a breast MRI or palpation-guided biopsy. Thank you very much for your attention. I hope this was helpful.